We want to welcome everyone that's joined. We're just kind of reminiscing, so join in if you have anything to share about Maine. We'll get started here in just a few seconds. The presentation was sent out this morning, so if you would like to access that. So Kerry, I have 12 o'clock noon, and so we'll go ahead and get started today and go over the information. I do have a couple of announcements, though, I'd like to make before we do get started. As always, I want to thank Allie Orwig with the Rural Health Association for helping support Zoom in the background for us. And Kerry Dunning will be presenting today, our swing bed consultant. I believe most of you know Kerry and have had interaction with her and listened to several of her webinars, but she is the swing bed consultant for us through the MB-QUIP program. Our next meeting will be in November 10th and 12th, and those are going to be regional meetings. Hospitals will be divided up in their regional groups as they were earlier in the year, and we will be focused on reimbursement. I will be sending the invitations to those meetings. It'll be an hour-long meeting after the call today. And so again, it'll be smaller groups. We're going to focus on wound care with our initial reimbursement discussion. So we'll want you to pull a medical record and the associated bill for a wound care patient. And we're just going to talk about some of the information that should be documented, should be included in the bill, and just answer lots of questions. Our focus this year is going to be a little more on making sure that you're getting reimbursed appropriately for your swing bed patients. So be watching about your invitation for that event for November. Also, many of you have already signed up for the certificate program. The certificate program will be provided through the State Office of Rural Health. Quickly, we reached our anticipated capacity, but we have been able to negotiate getting some additional funding for additional individuals to join. So we still have slots available. The deadline to register is October the 16th, which is this Friday. So if you're still interested and haven't registered yet, send me an email. I will include my email in the chat, and I will send you the registration link and next steps that you'll need to do so that you can do that certificate program. The certificate includes 7 programs that are 1 hour a month. Those would be in addition to our monthly education calls that we do provide, so I didn't want there to be any confusion there. In the certificate program, after the presentation, there is a short quiz. All of the content in that quiz will be covered well during the program, and each program builds on the other, so you need to complete all of the quiz and everything for that monthly program before you really should move on to the next. And we'll be sending out reminders and things related to that for those that do participate. And also, I did want to share, I had sent out an email earlier in the month regarding HRSA is doing a ventilator assessment. No guarantee that ventilators will be provided. I've heard from many of the hospitals, but if you're uncertain if you have reported the type of ventilator kit that was included in the most recent email that I distributed, please let me know, and I'll let you know if I've heard from your hospital, or we'll connect to make sure that we obtain the information that we need for that HRSA assessment and the potential for you to obtain a ventilator to support you through the COVID and flu season. And we will get the information together and get that submitted to HRSA. The turnaround time for the most recent assessment is by close of business tomorrow, so we do have to move quickly. We just received notification mid-afternoon on Friday ourselves that they were needing some additional supplemental information. So Kerry, I think that's all the announcements I have. So if you would like to go ahead and begin.
All right, thank you very much. That's an awful lot what you just heard. So we all know CMS is changing things routinely in any of the fields, and swing beds and skilled nursing seem to be catching a fair brunt of that. So I'll add the third announcement is when we find that new things have come out that are going to significantly change what you need to do or the way that we're looking at a policy, then I forward those to Becky to get out to all of you, trying to keep you as current as possible. The return favor is if you find something before me, please don't hesitate to tell me, because this is really a group project these days, trying to keep up with changes. So I want to spend today's time trying to take a slight pause, and I say pause very carefully, because I know that many of you are already in growing hotspots again, and we have flu season not officially started yet in most parts of the country. So what we're looking at is we've been through this first wave of the pandemic. It's becoming more obvious across the country that there is going to be a second wave of varying numbers. I'm not sure we can define all of that yet. What we can take control of is what we've learned and do some planning. So I want to review some things that may help you stop and think about what you're doing with your program, so that as flu and COVID and whatever else in life hits us, I'm hoping January 1 turns a calendar in more than one way, but up until that point, we've got a lot to kind of figure out. So when we're looking at COVID and flu, we already have, and I'm sure you're quite aware of your own state and where the hotspots are, but it's a state that's mostly in what I call fire colors. So those are moving. And all these stats came originally from CDC information or state offices of health, or the health departments in each state. And then the New York Times gathers these statistics and publishes them. It's actually always pretty interesting. So one, you can see the case count and the COVID map on the left of Indiana. The other one with the new cases, which I'm sure you're hearing, and I pulled this yesterday, and the last date they had published was October 11th, but there is an uptick in the number of cases. And then the bottom one is the flu activity in different jurisdictions. And so far, most of the country is not experiencing any flu. The ones in this kind of reverse picture for me, but those in darker green are the ones that are have some flu. Lighter green, yellow means that there is limited flu at this point. So what the problem has been, what we've talked about nationally since the first wave of this pandemic, was what happens to us when the flu and the pandemic cross into the same season. And it certainly looks like, with the hotspots going on across the country and the number of cases going up, that this may happen. So what that means for us is that we need to be doing our planning now, if you haven't already, but I just want to give you some reminders. First of all, we've talked a little bit about you have a choice for the type of swing bed admissions you want to take. And people have done all sorts of things. There have been programs that are all COVID. In fact, I think we have more than one of those in Indiana, and I think you had one or two swing bed programs doing vent patients at the height of the issue as it went around the first time. So all COVID means that your admissions criteria would have to reflect that. You would need to be letting your referring hospitals know that you are not going to be admitting non-COVID patients, that you're going to center in on COVID. I can tell you with some certainty across multiple states, what is interesting is those who did all COVID, and that has a lot of ifs, ands, or buts when I say all COVID, their market area expanded significantly. So I have a program, for instance, in North Georgia that decided to do all COVID. And they're pulling patients from South Carolina, North Carolina, Tennessee, and Georgia. It expanded across state lines with hospital systems trying to find placement for COVID patients. So that's one thing that you can look at. Now, with that obviously comes competency-based training. It comes with PPE needs. It comes with equipment needs. All of those you have to decide internally, and then look at your reimbursement versus what it would cost you to take those patients. We also have programs that went all non-COVID, and I will say they have not necessarily grown their swing bed census, but they've maintained their swing bed census by taking that approach, because again, they could expand their market area and talk to hospitals that weren't necessarily their primarily referring hospitals and say, you know, if you have what we were doing in swing beds prior to March 1 in this country, or actually prior to February in this country, we still have heart attacks, we still have wound care, we still have IV antibiotics, you know, we still have those types of patients. And there is some safety net in being able to say that your admissions are, as far as you know on the day admission, all, you know, COVID-free at that point. So that's the second way. Majority of the country fell in, I still contend, by accident, to a hybrid model where they had some COVID and some non-COVID. You may still elect to do that model. That may be what your area needs. That's up for you to look at your current referring hospitals, be talking to them, the beds you have available, the swing bed expectations as far as census and staffing. There are about 7 places in this country where the staffing is so short, they've had to limit swing beds, nursing home admissions, all sorts of things. I've got one nursing home that's 21 CNAs down and has been that way for 4 months. They're hiring LPNs to do CNA jobs. So, you know, you've got to take all those pieces into consideration. The other thing with the hybrid is you remember we're under those skilled rules where it says we should be keeping COVID and non-COVID in separate areas. And that just doesn't always work with the layouts of our rural hospitals. But you need to at least keep them on as opposite sides or through a doorway, you know, one side and the other. But more importantly, and I think this, I'm going to just say this over and over today because I've been surprised on nursing home surveys how many people are getting cited for the use of the equipment or improper use of equipment. You need to make sure that when you're leaving a room that you're taking all the precautions by removing PPE. You need, when you go back in to another room, that you have, you know, washed your hands, put on new PPE, and kept to all the standards that are in your policies, whatever that may be. Say that's what you're going to have to live by if a survey team comes in. And I think it's really important that that's an ongoing competency that all the staff goes through on a routine basis. When you're taking care of very sick people and you're moving fast because of their needs, it's not that hard to slip up. I had a friend yesterday who works in a hospital told me she can't tell you how many times she's walked in the front door of the hospital and looked at everybody in a mask and had to turn around and go to her car to get her mask. It's just not where we just do it so automatically, even though we all know it that work in healthcare. So I think reminders would be a great thing too. So whether you're looking at a hybrid or, you know, the what I'm going to call a post-COVID situation, when we start kind of coming back into our natural rhythm of providing care in rural hospitals, then we'll be back looking at medically complex admissions and therapy types of admissions. And therapy admissions are what we used to call weakness, but more so the ortho patients, people who've had strokes, people who have impairments. With our aging population, we're seeing more balance issues. Remember, we're living longer, we're trying to stay active longer. So those things that used to stop people from being active are now sort of a side effect that impact people. So there are a lot of things when somebody's been laying in a hospital bed for 3 days or more that show up, and that's where we need particularly to have some strong therapy care provided. So you have a choice here if you want to start looking at taking more medically complex patients. I think in critical access, and I think the way the world is headed, that is going to be a good business move on a critical access swing bed program, because right now PPS, they can take medically complex, but they have a finer margin. And then the nursing homes, when we're talking about taking medically complex, we get into safety issues. I mean, if somebody has some serious heart issues, it'd be families, patients, healthcare workers, all would probably rather have them in a swing bed where we have access to an ED, we have access to surgery, we have more crash carts, we have more trained RNs on duty, LPNs on duty, all of that's in place. We have RT that we don't usually have in nursing homes. So I think that's a place where the industry is going to kind of move us naturally. And for critical access swing beds and the way you are reimbursed, again, remember you have to be careful throughout your cost report year. That's something your financial people have to work with you on. You can build up your rate to cover the cost of the types of patients that we're beginning to see, again, as we age. And remember, between now and 2025, we have actually it started in 2017, but between now and 2025, this time period, 8-year time period, we have the largest number of new Medicare beneficiaries in our country's history, and probably the largest we'll ever see. It's a bolus that is fitting that post-World War II births that are now 65 and older. So what has your mix typically been? Is that what you want to do? And I'm not saying any of this is one way or the other. This is your decision. This is the planning piece. Stop and let's say, instead of just continuing to take what we've been taking or what we were semi-forced to take because of the pandemic, what do we want to look like when we start to get ready for a second wave and emerge out of that second wave? Do you still need to grow your program? Do you have enough swing beds now? Have you stopped, and I'm sure many of you have, but talk seriously about referring hospitals? Those of you that are in systems, obviously you may be more aware of the system admissions that are needed into your swing bed program, but stop, take stock in it, and plan what you want to be. And then whatever it is, make sure you have the right training, the right policies in place, and then also make sure that you let your referring hospitals know. So the next piece of this is, we've talked about this since I've been talking to you, which is now a couple of years, about tracking and quality. We're all working on quality together for critical access swing beds. And we're in the, I think, sort of on the downside of that, beginning to actually name some quality measures. And Becky and I are working with ICANN, which is in Illinois, to start testing some of the quality measures that they're looking at through some pre-testing they've done. But in the meantime, you've got things you need to know within your own hospital. For instance, what's your average length of stay? What's your discharge disposition? For instance, you know, are 70% of people are going home and home or to home health combined? That's great, but how many of those 70% are returning to your hospital within 30 days for an ED or a hospital stay? I know you're not penalized, but everybody else on earth is penalized for return to hospital and return to ED. The nursing homes are, the primary physicians are now, your large referring hospitals and system hospitals are penalized. So if you're taking an admission from one of those larger hospitals and they go home and have to go back to the ED, those hospitals are getting a financial penalty. So we need to start taking charge so that you can say, I'm paying attention to this. We know where these people are going. We are following up with them. We are making sure they're getting to their PCP appointment or their specialist appointment. So the more you start doing that as a routine piece of business, you're going to position yourself for more referrals from other hospitals. If nothing else, it may open discussions on things that you can do pre-discharge, whether that's education, working with families, working with more information going to primary care physicians, so there is coordination between the swing bed stay and these follow-up visits. I've noticed a change in the South. I don't know if you've seen it in Indiana, and I haven't talked to Illinois in the last couple of weeks, but in the South, we're beginning to see more referrals to rural health clinics because they can serve as the PCP, you know, after discharge from swing bed. So if that's something you have in your system, I'm not saying for you to take patients away from your PCP. That's bad business for everybody. But there are a whole lot of people that don't have a primary care physician, or they tell you they go Dr. Smith, but they haven't seen Dr. Smith in 5 years, so they really aren't an active patient. What we need is to make sure they're seen by somebody. So that's another option you can look at. And then the other thing that's real important is that you are listening to the case managers and discharge planners in the other hospitals that you're coordinating with. And some of that discussion really needs to be quality measures. When they are looking for placement of patients, what's important to them? What do they want to know about your program that they would define as a quality program so that they can say, I'm referring to this hospital because they have a really great swing bed program, they have really good outcomes, they track quality measures. Let's find out what they want, what they're looking for. Some of them will be standard things. And I'll go back to that average length of stay. That's not so much the case manager asking that, but many of you are beginning to take insurance business. And sometimes it's a hard sale to an insurance company when they realize they're going to pay more per day for that critical access swing bed because of the way you're reimbursed and the flat rate that the PPS swing beds and nursing homes are getting. You have to be able to show the quality in that. And the quality of that is that you are keeping them as a reasonable time period, whatever that works out to be, but you're also tracking them so you know they aren't going back to the hospitals, which costs insurance companies a lot of extra money every year, trust me. And then the piece that I talked about that I've seen now in several parts of the country, the quantity of staff is certainly hurting across the country. I don't know if you're caught up in any of those. I've got some states that can't find OTs, other states that can't find speech paths, so it's not even all of therapy, it's by discipline. As I've said, in the South, we're short CNAs drastically in several states. And then COVID has impacted all of this because people were worried about working in nursing homes, working in hospitals, and going home to families, as I'm sure all of you are more than aware of. So some of it is quantity and understanding that when you're looking at your swing bed program, what's reasonable number of beds for you to staff at this point. And then the next piece is always the quality of that staff. It's like the certificate program that we're talking about. It's like the webinars. There's a continual education flow needed for swing beds, mainly because it keeps changing. And I think Becky and I have had this conversation probably this week, but I certainly have it routinely. I have queried CMS more since the pandemic started than I have in my entire career. And that's because they have been putting out notices for skilled nursing, but not dividing swing beds out as a subset segment of that. So there are some of the rules where you would live under the hospital rules, the critical access hospital rules, and there's some of them that you would live under the swing bed. So I have to keep asking CMS which way, which flip of the coin do you want us to take here? I'm hoping if I ask them enough that ultimately they will separate out swing beds and we'll have a clear picture of what their expectations are. But for now, that competency-based training is one of the best things you can have. I'll tell you the other thing in a second. The surveys that are going on are primarily in nursing homes, primarily because of the number of deaths that have occurred in nursing homes. But secondarily to that, we do have swing bed programs getting surveyed across the country. They had already planned to do it this year. And then with the pandemic, if you've had COVID among your staff in your hospital, that could be a key that brings them in, since that's all now publicly reported data. So the competency-based training, again, for the PPE and being ready, survey ready, I think is really important for all of our programs. But just take that as a base level. That's part of the way that we deliver quality of care. The
Kerry,
second thing I know that, yes.
I'm
Go
sorry,
ahead.
wasn't sure when to interrupt you, but I had a question emailed to me that kind of ties into just what you were saying. You know, does the swing bed follow inpatient or SNF regulations? And the question is that the hospital does COVID testing with any new patient into our swing bed area. However, they do not have or require weekly testing on patients, but there's some new mandates for SNFs related to testing. So as applied to the swing beds, do they follow the SNF or do they follow the inpatient? And as you answer that question, it brought to mind what recommendations there are if a patient had been an inpatient in the hospital, had testing conducted, do they need new testing when they flip to swing bed?
So let's do the first one. At this point, without a clear direction from CMS, and that's an area that I have queried on, I would say follow your hospital rules as the primary. The other caveat I'm going to put on that, and Becky, this may be an area where you can help. I think you have to contact your state. The other problem is not only CMS not clearly defining just for swing beds, but each state has specifics on testing required. And I am not strong enough to keep up with 50 states. Actually, I work right now in 36 states, so I can't keep up with 36 states. So I think I would also check with the state. So that's the second, that part of it. The second part of it is, I think when they are coming into the swing bed, and this is a think. This is nothing that's been proven, but I'm watching the way they're doing their reviews. And we certainly had it in the national news all over the place. But one of the things that happens is somebody can be negative, 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 and then positive and be asymptomatic. So we have no idea which day they technically had it or didn't have it. We have people, I've got a good friend of mine who's in the hospital that's now been there for 3 weeks and asymptomatic, but can't get a negative swab. So we don't quite know how this disease goes person to person. So the safe way to me would be when they're coming into your swing bed program to have them tested specifically if they're not from your own hospital. If you have had a test while they were in your acute and your policy states some number of days, like maybe it's only repeated every 48 hours or every 72 hours, whatever it is, that you just follow your policy. And then Becky, if you can check with the state and see if Indiana has a different twist on that, it'd probably be your safety valve for that.
Yes, and Lisa Sorensen shared, as well as the last that I had heard from Jennifer Hembry at the state, is that she affirmed we follow hospital requirements, not SNFs for testing. And then Andrea also shared in chat that nursing homes are testing staff every 2 weeks. We are not testing hospital staff except for cause, such as exposure or symptoms. So just share.
All right, so again, that would be a state rule number one. But two, I'm going to say this over and over, whatever you do, your policy must match it. That's what survey teams will do to you. If you are doing one thing because the state told you to do it, that's great. But if your policy doesn't say that, they will jab you. So please, this is a time to review policies, because we have some policies that are coming out of this that are going to change things permanently. You know, and then we have some policies, honest to God, I've told nursing homes, don't kill the first policy, stick it in a file unused, because we're going to go back to that policy when the pandemic's over. So we're in a real mixed, and you're going to have to use common sense. And again, I think Becky, is good about taking the information and trying to get information from the state. If you have any questions, the safest thing is to contact the state. Then you have that either in writing or from a person that is known, so that you can use that as a backup for your decision making.
And I was
that's the problem right now.
For those of you that don't know Jennifer Hembry, she is with the Department of Health, and she's with the Acute Care Division, and she does an excellent job of getting answers or directing you where you need to contact when you have questions. So if you have something you would like forwarded to her, or a specific question from the state, I would be glad to help facilitate getting that answer. So.
And by the way, don't be shy, because whatever question you have, I bet my bottom dollar there are other people in the state that are trying to figure out the same thing. So it's good when it comes out in a group format. All right, so the last thing I wanted to kind of bring up is there is a current OIG, and OIG is Office of Inspector General. I always translate that into the FBI of healthcare. They are the ones that audit at direction from different federal agencies. So they are auditing from 2015 to 2019 critical access swing beds. And really what that came from, if you remember, I think it's 3 or 4 years ago now, there was a report done that showed falsely, by the way, and it was proven to be false later, how much money critical access swing beds were making over what they were spending. And the numbers were, I don't think, even just slightly exaggerated. They were pretty horrifically exaggerated. But that has set up a worry about it. And of course, the government's always looking for, are we spending too much money in a certain area? So there's nothing you can do about the 2015 to 2019 now. What you can do is 2020. And the key to everything is documentation. It is your IDT documentation. It is your nighttime nursing or your second shift nursing documentation. That rolls into how that defends what therapy is doing. It goes into what our length of stay is, honestly. If somebody can walk around in the morning, and that's the documentation we're based on, but we know they're having problems at night. They're not safe at night. They're going home by themselves. They're an elderly patient. They can't self-medicate or whatever, or walk themselves to the bathroom. If we do not have that documentation, we can't support the length of stay for keeping a patient. So any documentation, your RT, if we're doing med reviews, all of those things you can take charge of right now. And you need to set up a system where you have some kind of chart review going on. And as Becky said, we're going to spend this year looking at subsets of this, but all of that should drive you into, as a team, paying attention to what you're spending money on. You can get paid for everything provided to a patient during a swing bed stay. The issue is not that you're going to get paid. The issue is, should you have been paid for that? Easy example is a physician that still has standing labs. Even though he or she saw the same patient in the hospital 2 days earlier and saw those labs, we still have physicians across the country who want standing labs when they go into swing bed. That's not a necessary expense to bill to Medicare. So we need to be looking at why we're doing labs, or why we are doing blood work, why we're doing 5 CTs, during a swing bed stay. And I'm hoping I'm exaggerating on all of these. But it's something for you to review. What you put on that claim should be medically necessary. And when Becky asked you to bring the chart, our PICA wound care chart for the classes we're going to be doing in November, I want you to bring the claim. I'd also like you to bring a detailed bill, or what they call an itemized bill. And the reason that's important is that itemized bill shows every single penny you spent on that patient. And it's funny when clinical people look at that and they see all of a sudden that there were, maybe 6 flu shots given to that one person. That's probably not accurate. But sometimes it takes a clinical person to weed through all that information to realize that that particular medicine can't even be given that many times in a day, or in the case of a flu shot, wouldn't be repeated, et cetera. So you've got to look at your cost. You've got to do, the other thing I think we need to be paying attention to is our use of medications. This is we've talked about, this is a setting where we can slow up a little bit and see if we can reduce the number of meds, alter the meds with a pharmacist and physician help to better doses, maybe even reduce medications and so forth. Reduce dosages. So all sorts of things where you can, as a team, train yourselves to be cost efficient. The easier it's going to be to get through surveys and audits. So this is a planning time. This is a time for you to take any of those bullet points that I just set forth there and start working on them as a team, or maybe you already have conquered some of those. Fantastic. Then keep running through the next ones, because things like quality and cost and tracking are ongoing measures and ongoing changes in our lives these days. So Becky, I'll see if there are any other questions.
That was the only question I had emailed to me today, but we are over just a little bit on our time. But if you do have additional questions, send those to me. My email address is in the chat, and we'll work to get those answered for you. And so everyone, be watching for your invitation for the November regional meeting. It'll be a 1-hour meeting where we're focused on wound care, and we'll also list out the documents that we would like for you to bring to the meeting. So Hope today was helpful, and stay safe, and thank you so much for attending. Bye-bye.